We're here today to discuss our recent publication, Colorectal Cancer in 18 to 49-year-olds, Rising Rates, Presentation, and Outcome in a Large Integrated Health System. So Dr. Vakil, tell me, what inspired you to want to do this study?
Well, it's an interesting story. Several years ago, I was in New York at a conference, and I looked at the New York Times delivered to my hotel room, and there was this engaging story about a young woman, I think it was, with colon cancer in her 40s, and it described her ordeal and how little was known about colon cancer in young people. And that got me thinking that we should be studying this condition and trying to see if we can contribute to our knowledge in this area. So Kristen, you did all the hard work in accumulating the data. So can you tell us what all the challenges were that you faced during the conduct of this study?
Well, certainly the most challenging was doing the symptom analysis. So in our Aurora Cancer Registry, the symptom data is not captured as discrete data, but rather as free text. So it was a very painstaking process to do the symptom analysis by hand. And also critically important was our cohort assembly. So our cohort is strictly adenocarcinoma morphologies limited to the colon and the rectum. So this was important because a recent study showed that the rising incidence of colorectal cancer in young persons may be overestimates due to carcinoid tumors being included in previous data sets that were analyzed. Dr. Vakil, what were you not expecting for us to find in this study?
Yes, it's an interesting question, and there were a few unexpected results that we had. The first unexpected result was I was not expecting to see colon cancer in people as young as 18 years of age. The second unexpected finding was that, contrary to all the reported literature that we have, we did not see ethnic differences in survival in our cohort. In particular, African Americans and Hispanic patients in our survey did just as well in our study as Caucasian Americans. And I think this is an important point because we are struggling as a nation to get the same outcomes in people with colorectal cancer and other cancers across ethnic groups. So that was another unexpected finding. And the third unexpected finding that I had was I was really surprised by the age group between 18 and 45, that they had a 49% incidence of a family history of colon cancer. And I think that is telling us something, that if you can have a family history and get colon cancer at such a young age, there's probably something that we should be looking for. So Kristen, what's your message from our study to managed care organizations?
Great question. So the American Cancer Society recommends, and ACG suggests, that in average risk individuals, colorectal cancer screening should commence at age 45. Our data certainly supports these suggestions and recommendations. It's also important to remember that in patients that are not at average risk, such as those reporting with alarm symptoms and with a family history of colon cancer, that stool-based tests are not recommended. What would be your message to managed care and those that are creating the guidelines?
Yes, I think I would like to emphasize the separation of non-invasive tests such as stool-based tests, which should not be done in this population. I think this needs to be emphasized because there's confusion in managed care settings about which tests should be done when. The other important message I have is that we haven't spoken much about the 18 to 45-year-old population. As I mentioned earlier, I'm struck by how frequent a family history is in this population. 49% is almost half the population have a family history. So surely we should be focusing on even the 40 to 45-year-old age group and targeting those who have a family history for colon cancer and considering starting colonoscopy even earlier than 45 years of age. So Kristen, do you have a message for clinicians today? What do you want to say to them?
My message to clinicians would be to have a lower threshold for colonoscopy, especially for patients reporting with alarm symptoms such as rectal bleeding, weight loss, anemia, and rectal and anal symptoms.
Yes, it's true that when we look back at history, I can remember the time when if a young person came to the office with rectal bleeding, we'd be inclined to say, I wouldn't worry about it, it's probably from hemorrhoids. And we did a study several years ago, which was published in JAMA, that showed that the pattern of bleeding is not predictive of the underlying lesion. And when you couple that study with this study, you can now see that we should not be dismissing symptoms as probably being related to hemorrhoids or other such things without doing the test that we need to figure out what's going on.
So Dr. Vakil, one thing that I also found surprising about our study was that we didn't see any difference in survival amongst our racial and ethnic groups. What are your thoughts on how we as a system achieve these outcomes?
I think it's a complicated question, and I think we first should qualify the response by saying that we didn't actually study this, but we found this unexpected result. And of course, we can offer some explanations of why that may be the case. I think the first thing is to remember that the study was done in Wisconsin, and access to healthcare is rated by the government to be very high in Wisconsin. So our population included urban and rural populations, and access to healthcare is very important if you're going to achieve these outcomes. So I think the statewide success of access is important. The second is an integrated healthcare system offers many advantages. Because we're integrated, we offer care services that other systems do not offer, for example. So we have provisions for the underinsured, we have provisions for the uninsured, we have also techniques to enhance compliance with screening guidelines. We also have outreach programs into communities, particularly into minority communities where compliance with screening may be diminished. So we have pointed out in our study that these results clearly are different from the nationwide results and may not be applicable to other populations. But it does provide a glimpse into how one can accomplish this outcome. So it is possible to accomplish this, and we need to study how we can do this as a nation as opposed to one state or one region.
What direction do you think future research should take?
So there are several aspects about research into colon cancer in young individuals. I think we've already touched upon one topic. We need to eliminate disparities in outcomes in cancer outcomes. So that's an important target of understanding why some people don't comply with guidelines on screening, why other people do but still do so late and therefore have poorer outcomes. So we really need to improve compliance and research why people do things in the way they do and why some people don't participate. The other important thing, I think, is we need to develop risk calculators by comparing young people with colon cancer to young people without colon cancer, and develop some sort of model to say, if you belong in this category, say you've got a family history of colon cancer, you're obese, you have more than 2 relatives who've had multiple polyps, then you fit a model which says you should have colonoscopy at a younger age. We don't have such a model at the moment, and the only thing we have, as I pointed out earlier, is a family history of colon cancer as being an important marker. So we need these types of predictors. And finally, of course, the most important area of research is we need a genetic marker to tell us this is why this young person is at risk. We need a blood test or a stool test to tell us this is the person at higher risk in whom we're going to focus all our energies. This would target our interventions to those most at risk and remove people from screening modalities who are not at risk. So that would be the most important goal.
Excellent, thank you.
Thank you very much for your interest in our study.